There's something your doctor has almost certainly never told you. And it is not because they do not care. It is because the system they work inside was never designed to catch it. Every single day, people over 60 walk into medical offices feeling perfectly fine. Their blood pressure gets checked. The numbers look acceptable. They are told everything is under control. They drive home. They cook dinner. They go to sleep. And while they sleep, something dangerous is happening inside their bodies that no one in that office ever measured, ever discussed, or ever thought to look for. I have spent decades working inside hospital systems, sitting across from patients, reviewing test results, and sometimes standing at bedsides after emergencies that should never have happened. And one pattern keeps repeating itself with a consistency that should alarm every person over the age of 60. People who felt completely fine. People who had normal office readings. People whose doctors had no obvious reason for concern. And yet something was quietly destroying their cardiovascular system every single night while they slept. The assumption most people carry is this: if I felt sick, I would know. If my blood pressure were dangerously high, my body would send me a signal. A headache, dizziness, something. But that assumption is one of the most medically dangerous ideas that exists. High blood pressure earned its reputation as the silent condition for a very specific reason. It produces no reliable warning signs. None. And at night, when you're unconscious and unaware, it becomes more dangerous still. Here is what most people do not realize about how blood pressure actually works across a 24-hour period. Under normal, healthy conditions, when you fall asleep, your cardiovascular system does something remarkable. Your blood pressure drops. It falls by roughly 10 to 20% below your daytime levels. Every single night, without fail. This is not a coincidence or a side effect of rest. It is an active, essential biological process. During those hours of reduced pressure, your heart muscle repairs microscopic damage. Your arterial walls recover their elasticity. Your kidneys process waste products and regulate fluid balance. Your entire cardiovascular system uses that window of lower pressure to perform maintenance that simply cannot happen when you are active and upright. It is one of the most important things your body does, and it does it invisibly, automatically every night. Now here is where the story changes after 60. As we age, our arteries gradually lose their flexibility. The walls stiffen. The autonomic nervous system, which is responsible for orchestrating that nighttime pressure drop, begins losing its precision. The signals that tell your blood vessels to relax during sleep become weaker, less consistent, less reliable. For a growing number of people in their 60s, 70s, and beyond, that critical nighttime dip simply stops happening. The pressure does not fall during sleep. In some cases, it actually rises. And the person sleeping through all of this has absolutely no idea. They wake up feeling tired. Their thinking feels foggy in the morning. They assume they slept poorly or that aging just feels this way. But the real explanation is something their morning coffee will never fix. And their doctor, reviewing a single blood pressure reading taken during a brief office visit, has no way to see it. To understand exactly how dramatic this gap can be, consider a real clinical scenario. A patient comes in for a routine appointment. Blood pressure reads 118/76. Completely normal. Textbook perfect. On paper, this person has nothing to worry about. But then that same patient wears a portable blood pressure monitor for 24 hours. They go home. They eat dinner. They watch television. They fall asleep around 10:30. And at 2 in the morning, while they're deeply asleep in their own bed, the monitor records a reading of 168/104. That is not mild elevation. That is a hypertensive crisis, happening silently, repeatedly, with no one watching and no symptoms to report the next morning. How does something like this happen? There are several mechanisms that work together, and each one becomes more common as we age. First, there is the medication timing problem. Most blood pressure medications are taken in the morning. That is the convention. That is what patients are instructed to do. But the protective effect of most antihypertensive drugs peaks within a few hours of ingestion and then gradually diminishes across the rest of the day. By the time midnight arrives, the coverage may be reduced to a fraction of what it was at 9 in the morning. The window of greatest vulnerability, when natural dipping should be protecting you, is the same window when your medication has worn down the furthest. Second, there is the hormonal rhythm disruption. Cortisol and adrenaline, the body's primary stress hormones, are supposed to follow a predictable pattern. High during the day, dropping off in the evening, reaching their lowest point during the night. But in many older adults, this rhythm becomes disrupted. Instead of falling during sleep, cortisol levels surge. An elevated cortisol at night directly drives blood pressure upward during the exact hours when it should be at its lowest. Third, there's fragmented sleep. Every brief awakening during the night, even the ones you do not consciously remember the next morning, triggers a brief spike in sympathetic nervous system activity. The heart rate jumps, vessels constrict, pressure surges. If this happens 5, 8, 10 times a night, the cumulative cardiovascular strain across weeks and months and years is enormous. And because none of those awakenings register as memorable events, the person has no idea they occurred. The medical term for someone whose blood pressure does not fall during sleep is a non-dipper. And the statistics around non-dipping should be part of every conversation doctors have with patients over 65, but they almost never are. More than half of adults in that age group are non-dippers. Not a small minority, not an unusual edge case. The majority, more than 50% of people over 65 are experiencing cardiovascular risk that their daytime blood pressure readings will never reveal. And the consequences of this hidden pattern are not minor. Research has consistently shown that non-dippers carry a risk of cardiovascular death 3 times higher than people with identical daytime readings who do maintain normal nighttime dipping patterns. Same morning number, same medications, same diet, 3 times the risk, purely based on what happens during those 8 hours of sleep that no standard appointment has ever measured. There's an even more dangerous variation called reverse dipping, where blood pressure does not just fail to fall at night, but actively rises above daytime levels during sleep. For reverse dippers, stroke risk is estimated to be 4 to 5 times higher than normal dippers with similar daytime readings. And these individuals sit in their doctor's offices looking completely healthy because by every measurement their physician is actually taking, they are. Now let us talk about things that may already be in your home, sitting on your kitchen counter or in your pantry, silently making nighttime blood pressure worse. These are not exotic or obscure dangers. They are common, everyday items that the majority of people over 60 never connect to their cardiovascular health. The first is licorice root. This appears in countless herbal teas marketed as calming, soothing, and perfect for evening relaxation. It is natural. It smells pleasant. It feels like a gentle, healthy choice before bed. But licorice root contains a specific chemical compound that blocks an enzyme in the kidneys responsible for breaking down cortisol. When that enzyme is inhibited, cortisol accumulates in the bloodstream. At night, during the exact hours when cortisol should be at its lowest. The result is an elevation in nighttime blood pressure that the person drinking the tea will never feel happening but will experience in the form of accumulated arterial damage over time. Check your tea labels carefully. Licorice root appears under several names, including sweet root and a long botanical term beginning with G that sounds nothing like licorice. It also hides in side products labeled simply as herbal blends or natural flavoring. The second hidden factor is evening alcohol. And what the research actually shows about this tends to surprise people significantly. The initial effect of alcohol on blood pressure is a mild reduction. That part is real. Many people who drink in the evening notice they feel relaxed, and that relaxation is partly physiological. But 3 to 4 hours after consumption, as the body begins metabolizing and clearing the alcohol from the system, the sympathetic nervous system overcorrects. It surges. Blood pressure rebounds sharply. In many cases, the peak blood pressure of the entire 24-hour period occurs at 3 or 4 in the morning, directly as a consequence of a drink taken before dinner. The person is asleep. They feel nothing, but their arteries are experiencing a pressure spike that, repeated night after night, leaves measurable damage. The third hidden factor involves a specific interaction between grapefruit and certain blood pressure medications, particularly the class of drugs known as calcium channel blockers. Grapefruit contains compounds that inhibit a liver enzyme responsible for breaking down these medications at the normal rate. When that enzyme is blocked, the medication accumulates to higher levels than intended. What was formulated to provide a gradual, controlled effect becomes unpredictable in its intensity and duration. The drug does not behave as designed. And this unpredictability is most dangerous at night, when no one is monitoring, when there is no professional nearby to identify symptoms, and when the person is not in a position to respond. So what do you actually do with this information? How do you find out what your blood pressure is doing during those 8 unmonitored hours? The answer is a test that exists, works well, is widely available, and is almost never ordered unless the patient asks for it by name. It is called ambulatory blood pressure monitoring. You wear a small cuff attached to a lightweight device for 24 hours while living your normal life. The device takes automatic readings at regular intervals, including throughout the night. When you return the monitor and the data is analyzed, your physician can see exactly what your pressure does during sleep, whether you are dipping normally, whether you are a non-dipper, whether your pressure is actually rising at night. This single test can reveal information that years of standard office appointments have completely missed, and yet a large majority of adults over 65 have never worn one. Ask for it specifically, using those words at your next appointment. If you do not ask, it almost certainly will not be ordered. The second test worth knowing about measures something called urinary microalbumin. This is a laboratory test performed on a urine sample. It detects tiny quantities of a protein called albumin that leaks from the kidneys into urine when the kidney tissue is under sustained pressure stress. Microalbumin appears in measurable quantities years before kidney function declines enough to show up on standard blood tests. It is an early warning signal, a biological marker that says the pressure your vessels are experiencing is already beginning to affect your organs, while there is still meaningful time to intervene and change the trajectory. The third test is called oxidized LDL. Most people are familiar with LDL cholesterol as the one typically called the bad type. Oxidized LDL is what happens when those cholesterol particles are chemically damaged by unstable molecules in the bloodstream. The result is a form of cholesterol that is significantly more destructive to arterial walls than standard LDL. It is directly associated with accelerated arterial damage, which is exactly what sustained, undetected nighttime hypertension produces over time. Standard cholesterol panels do not measure it. You have to ask for it specifically, and it provides a window into arterial wall health that no routine lipid panel will ever show you. These 3 tests together paint a picture of cardiovascular health that no standard annual checkup was ever designed to capture. They are not experimental. They are not cutting-edge or theoretical. They are established, clinically validated tools that simply do not get ordered unless a patient walks and no one asks for them. Write these 3 names down right now. Ambulatory blood pressure monitoring, urinary microalbumin, oxidized LDL. Those 3 phrases written on a piece of paper that you bring to your next appointment represent the single most impactful cardiovascular conversation most people over 60 have never had with their doctor. Now let us talk about something that has been studied in genuine clinical trials and has real, peer-reviewed evidence behind it. A plant that has been cultivated across multiple continents for centuries, consumed as a beverage, and investigated by independent research teams looking at its effects on blood pressure. The dried flowers of a particular hibiscus plant, specifically Hibiscus sabdariffa, have been tested in multiple controlled clinical studies. The results are consistent enough to be medically significant. The flowers contain a group of naturally occurring antioxidant compounds responsible for their distinctive deep red color. These same compounds are found in blueberries, in certain varieties of grapes, and in other deeply pigmented fruits and vegetables. They reduce oxidative damage to blood vessel walls. But hibiscus does something more specific than general antioxidant activity. It inhibits the same enzymatic pathway that a major class of pharmaceutical blood pressure medications targets. This is not folk medicine or anecdote. It is a documented biochemical mechanism that has been replicated in multiple independent studies. Clinical trials have measured blood pressure reductions in the range of 8 to 14 points on the upper number in patients with mild to moderate elevation who consumed hibiscus tea daily over a period of weeks. Preparation matters significantly. Most people who try hibiscus tea make it far too weak to produce any meaningful effect. Use 10 grams of dried flowers, not tea bags, not blended herbal mixes, actual dried hibiscus flowers. Steep them in water that is hot, but not at a full rolling boil, for a minimum of 10 to 15 minutes. The extraction time is not arbitrary. The active compounds require sufficient contact time to transfer fully into the water. When properly brewed, the tea should be a deep, rich burgundy color, almost resembling red wine in its depth of color. If it looks pale or pinkish, it has not steeped long enough. 3 cups across the day is the dosage reflected in clinical literature. But timing matters, particularly for nighttime blood pressure. The most important cup is the one consumed 1 to 2 hours before sleep. That timing appears to have the most meaningful influence on what the cardiovascular system does during the hours that follow. One essential caution here. If you're already taking blood pressure medication, adding hibiscus tea to your routine without informing your physician is not wise. The effects are real, which means the combined influence of medication and hibiscus can be additive. Your doctor needs to know. This is not a reason to avoid it. It is a reason to have a conversation first. And on the topic of medication, there is something about timing that most patients and even many physicians have not fully incorporated into practice. The largest study ever conducted specifically on blood pressure medication timing enrolled over 20,000 participants and followed them for 6 years. Researchers divided participants into 2 groups: those who took their medications in the morning as conventionally instructed, and those who took the same medications at the same doses at bedtime. Everything else remained identical. The results were striking. The group taking their medications before sleep experienced nearly 50% fewer cardiovascular events, including heart attacks and strokes, compared to the morning group. Nearly half the risk from the same drugs, at the same doses, on the same patients, simply taken at a different time. This finding has been debated and discussed in cardiology circles, and individual responses vary depending on the specific medication and the individual patient. Some medications should absolutely not be taken at bedtime, including diuretics, which would create obvious practical problems during the night. This is not a change anyone should make on their own without a direct conversation with their physician. But it is a conversation that is absolutely worth initiating. A single question at your next appointment about whether bedtime dosing might be appropriate for your specific situation, given your medications and your medical history, is a question that has changed outcomes for many patients who thought to ask it. Let me bring everything together now into a clear, simple set of actions, because information without action does not protect anyone. Tonight, before you go to bed, go to wherever you keep your herbal teas and read every label. Look for licorice root, which also appears as sweet root or under various botanical names. If you find it in anything you drink in the evenings, relocate it or remove it. That takes 3 minutes and could be meaningfully impactful. Be honest with yourself about evening alcohol. Not judgmental, just honest. If it is happening regularly and relatively close to bedtime, the rebound pressure spike happening at 3 in the morning is real, whether you feel it or not. You do not have to eliminate anything. Simply shifting the timing earlier, with a meal rather than before sleep, reduces the overnight impact substantially. Write down 3 things on paper: ambulatory blood pressure monitoring, urinary microalbumin, oxidized LDL. Put that paper somewhere you will not lose it. Bring it to your next doctor's appointment. Those 3 items represent a complete, affordable, clinically meaningful cardiovascular assessment that almost no one over 60 has ever received because almost no one has ever asked for it by name. Ask your physician about medication timing, specifically whether your particular medications, given your particular history, might be appropriate to take before sleep rather than in the morning. The conversation takes 2 minutes, and the evidence behind the question is substantial. And if you want to begin incorporating hibiscus tea, do so thoughtfully, using proper preparation and real dried flowers, and mention it to your doctor if you're on blood pressure medication. What I want you to carry away from everything covered here is something deeper than a list of tests or teas or timing adjustments. I want you to understand that the standard tools of routine medical care were never designed to detect what is happening to your cardiovascular system at 2 in the morning. They are good tools. They serve important purposes, but they have a blind spot. And that blind spot sits precisely in the hours when some of the most consequential things that happen to your heart and vessels and kidneys are occurring. The human body is extraordinarily good at absorbing damage quietly. It compensates. It adapts. It keeps functioning without sending distress signals until, sometimes suddenly, a threshold is crossed that cannot be uncrossed. In many of the most heartbreaking cases I have witnessed over decades in clinical practice, the warning signs were already present in data that was never collected, in tests that were never ordered, in questions that were never asked. And in a meaningful proportion of those cases, a different conversation at a different appointment might have changed what came next. You're not being difficult when you ask your doctor about nighttime blood pressure. You're not being demanding when you request specific tests by name. You are being a fully engaged participant in your own health care, which is exactly what the research consistently shows leads to better outcomes. Patients who bring lists, who ask informed questions, who follow up, they receive better care. Not because their doctors care more, but because the information exchange is richer and the decisions made on that basis are more complete. You now have specific information that most people walking into medical offices do not have. You know what to ask for. You know what to look for at home. You know which questions matter and why. That knowledge is not decorative. It is actionable. It has the potential to reveal something that has been happening every single night without detection and to change the trajectory before a threshold is crossed that cannot be reversed. Your cardiovascular system has been working without pause, without vacation, without complaint, every hour of every day of your entire life. Every contraction, every beat, every pressure wave moving through your vessels. It has never once asked for acknowledgement or asked you to pay attention. The very least we owe it is to ask the right questions, run the right tests, and have the right conversations while there is still time for those conversations to matter. Walk into your next appointment prepared, with your list, with your questions, with the specific names of the tests you want discussed. That preparation is not a small thing. In medicine, it changes everything.